So the next presentation will be one of the members of, and I had it wrong, it's Paul's daughter rather than Pot's daughter. So thank you very much for that presentation. Dr. Jan de Maeseneer is the medical doctor researcher. He's at the University of Ghent, which is a member. He's also with the head of the Network Towards Unity for Health. He's been one of the leading driving forces here in looking at primary care and looking at community medicine through the whole process of the Global Forum. So welcome you.
Thank you very much for this opportunity to share some ideas about something we together with Paul Worley, the Dean of Medicine of Flinders University. We were sitting on a bus at the conference and we were discussing about specialty training in health professional education. Well, what are we doing now and how well are we doing? And so that brought us to this reflection that I want to share with you. And the background of this is that we see actually a huge variation in the organization of postgraduate specialty training in health professional education worldwide. The dominant model is the so-called UK model with a college in the UK, most of the time a Royal College, of physicians, of surgeons, of orthopedics, of psychiatrists, and so on. Most of the time, it are strong monodisciplinary bodies that are very influential in policy debates that are in charge of the postgraduate specialty training. Sometimes you have a hybrid system, like in the USA, where universities do the residency training to college specification. And in Europe, there's also the model of universities organizing a master after master program. But the features that all those projects share is that there is a lot of fragmentation. We see an increasing subspecialty actually looks, for instance, at cardiology, where actually there are the cardiorhythmologists who take care of 4 square centimeters of the human body. Important 4 square centimeters, but it is an enormous amount of subspecialization. So the question we want to ask is there a need for a paradigm shift for specialty training in health professional education in order to respond better to the changing healthcare needs of society? And of course, those needs are changing quite a lot. If you look at the epidemiological transition, you see on this slide that the number of people in dark blue with more than 8 disorders, which really indicates multimorbidity, is increasing with age. And as you can see, already from the age of 55, there are people with 3, 4, 5 comorbidities. So multimorbidity becomes the rule rather than the exception. And if you look at the social distribution of the multimorbidity, and you see in the red line the people with the lowest social status, then you see that for each age group, the number of people with multimorbidity is much higher in the lower social classes. So there's a social gradient as well. So this is a double challenge. And how are we going to deal with this? In an environment of continuous scientific and technological evolutions, in an environment where socioeconomic developments lead to an increasing social gradient in health, in an environment with cultural developments and the changing position of the patient, and in a world where every problem is global and there are no more local problems. How can the postgraduate educational system be responsive to those new challenges? We will start with 5 reflections. The first reflection is the following. Is generalism limited to the discipline of family medicine? Or do we need, also in the different specialties, a more generalistic approach? Can the concept of EPAs help us, and trustable professional activities, interdisciplinary supervision of postgraduate training, could that be an option to bring it more together, to have more unity in postgraduate training? And of course, the internet changes the role of doctors as memorized content experts towards synthesizers and interpreters of the evidence that is easily and democratically available for everybody. We discussed it a lot during this conference. And finally, integrative models of medical practitioners are more possible now than ever before due to that changes and this technological environment. Second group of reflections is about the distinction between the core content of a discipline and the development of procedural skills. Yesterday we saw in the gaming illustration that a lot of technology helps us now to acquire procedural skills. The role of physician assistants and technicians in healthcare will change the task of doctors, for instance. And will there be an end of the income models of subspecialists who rely on procedural monopolies, which actually is in a lot of health systems still the case. Third group of reflection, who pays the trainees and the supervisors? Is the remove of the training out of hospitals, yes, into ambulatory care and private practice settings, but what does that mean for the organization of the training? And there is a debate ongoing on the length of training until unsupervised practice. And what we see is an increase in the length of training in a lot of countries, especially when it comes to high-tech specialty training. Fourth group of reflections, the difference between certification and license to practice, credentialing. In a lot of countries, this difference becomes more and more important. Also in Belgium, where there will be in the future a system of recognition of the professional qualification and then all kinds of tests that will prepare for the license to practice. And very important will be the maintenance of license according to criteria with a reassessment of that criteria, for instance, every 5 years. In the interest of patient safety, this is certainly a good solution, but often is sullied with protectionism and prejudice by the professionals. There is a need to construct an evidence base around maintenance of expertise that is not developed by those who have the most to protect. So that needs also a kind of democratization process. And the last group of reflections is about professions. Medicine, nursing, social workers are professions, which includes that the profession has control over certification, standards, and credentialing. And you all know by the work of Elliot Freitzer how important professions are, especially the profession of medicine, and how they maintain their power, not only in training, but also in selecting those who can be trained for the programs. So professions have to change in order to be more socially accountable, as the previous speaker said. And status as a profession should be seen as a gift from society, not as a claim by a group. Finally, tension between professional versus government control is very evident in the postgraduate training space. So what we did in Belgium, we adopted the model that is European one, where previously we had a Federal Ministry of Health designed that framework, mainly focused on learning by doing. Within the European Bologna Agreement, it was decided that universities and the Ministry of Education could take responsibility for postgraduate specialty training. Specific tracks for the different specialties with established learning outcomes were designed. And final certification by the Ministry of Health, by certification committees composed 50% of university, 50% of representation of professional bodies. The advantages are joint interprofessional curriculum modules, integration with innovative views from basic medical sciences, and inputs from other faculties like economy, anthropology, and management. And this facilitates the creation of protected time to harmonize workplace learning with other learning processes. So the previous model was this, where you had the undergraduate curriculum and then the colleges that organizes different tracks, societies and colleges for different specialties, but they were not linked to one to the other. They were isolated and working in silos. Fragmentation was the result of this. What we propose is a new concept where the undergraduate curriculum leads to different tracks, family medicine, internal medicine, gynecology, but that share a lot of learning modules. For instance, modules based on ethics, modules based on decision-making, modules based on other components that they share. And also the inclusion of other faculties like management, economy, anthropology will be important in order to go for the new model. Integration will then be the end, and we hope that by changing the postgraduate training, we will probably be able to change also the quality and the outcome and lead to more integrated approaches, which will be absolutely needed in the field of multimorbidity that we will facing in the future. So that is the kind of paradigm shift we want to go for, to this more integrated approach where universities take their full responsibility to be in charge of the postgraduate training in order to better respond to the needs of society. Thank you.
Well, a brief follow-up. And one of our main themes here the last couple of days has been the need to be connected better to the community. And the question is are the universities themselves closely enough connected to primary and secondary care to actually provide the services that we need going forward?
I think that is absolutely the challenge. If universities want to assume this responsibility, and I think in order to address the challenges, this will be needed. They will also have to organize them as an integrated part of the healthcare system. That means that they have to link up with academic centers for primary care, community health centers, NGOs, but also with secondary care specialists, with specialists working in private practice, in order to really create a more realistic, but also a more relevant field of training, of workplace training for the postgraduate trainees, so that they can better prepare for the future roles in society.